Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. This is your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I have been teaching anatomy and physiology since 2002. Today we're going to start talking about the respiratory system. If you're following the progression of topics, you may be expecting the immune system by now, but I'm currently working on some immune system tutor videos, and when they're completed, I'll record some episodes based on that content. In the meantime, I'm going to jump to the respiratory system. You're probably already aware that the respiratory system is all about breathing and exchanging carbon dioxide for oxygen. But that's not all. There's a lot of functions of the respiratory system, and we're going to talk about them. But first, I have a guest today. Recently, I sat down with David DeVenti, who was an instructor of medical assisting and supervisor of allied health and workforce development at Camden County College in southern New Jersey. David and I talked about being a medical assistant, what it takes to become one, and how rewarding a career it has been for him. It's an incredibly informative conversation about a great career option for anyone interested in anatomy and physiology. I've known David DeVenti for many years because he grew up with my wife's brother and has been a lifelong friend of his. Dave and I got to talking at my brother-in-law's 50th birthday party a few weeks ago, and I had no idea he was a medical assisting instructor. So I invited him on the podcast to talk about medical assisting, and he was gracious enough to give us some of his time so we can all learn about the career of medical assistant. So let's take a few minutes to learn all about medical assisting from David DeVenti of Camden County College in southern New Jersey. All right, I have Dave DeVenti, who is a professor of medical assisting at Camden County College. Dave, thanks so much for joining me on the podcast.
Steve, it's an honor to be here. Thanks a lot for inviting me over.
Anytime, because I love having people I know who are doing things that are pertinent to my audience, so we can talk about it. So for the listeners, tell me what you do and where do you do it?
Great. My name is David DeVenti. I am an instructor at Camden County College here in New Jersey. I've been an instructor for about 8 years now. I oversee 2 fully equipped medical labs. One is more hospital-based. We have 2 fully functional hospital beds and mannequins, IV poles. And the other one is more ambulatory, more like a doctor's lab or a doctor's office. 2 exam tables, an EKG machine, phlebotomy equipment, more mannequins, and fully stocked for doctor's office simulation. And I have a passion for teaching and preparing future medical assistants here in New Jersey.
So that's a pretty robust setup you have down there. What you said you've been teaching medical assisting for 8 years. Has it always been at Camden County?
I've always been teaching here at Camden County College. That's correct. Yeah.
What got you into teaching medical assisting? What kind of background do you have?
My medical career started about 20 years ago. So I was a medical assistant at the hospital, and I really enjoyed that. I did about 15 years or so at a local healthcare system here in New Jersey. And teaching was always a bit of a dream of mine, and a chance encounter with a patient actually led me to the path here to CCC. I started out part-time, and that transitioned into a full-time position. And now I serve as the supervisor of allied health and workforce development here.
So you said it was a patient, so they inspired you to go from clinical practice into teaching?
This patient was a teacher, and something told her that I'd be good at teaching. And she thought, hey, maybe in the future, if we're looking for an instructor, we'll give you a call. And about 6-7 months later, the phone rang, and she said, hey, we need an instructor for the clinical portion of our medical assistant program. Luckily, the hospital that I was working for was flexible enough to give me 2 days off a week so I could teach. And it's been a dream job ever since, to be honest with you.
That is very, very similar to how I started in teaching.
There's a book called Atomic Habits. James Clear And in this book, he talks about goals versus systems. Goals being attainable, but it's the love of the process, or he refers to them as systems that truly bring the reward. And it's not about reaching the goals, it's more about the journey of growth. And the reason that resonates with me is because that's kind of like my projection into where I am now. It wasn't necessarily a goal of mine to become an instructor, but because of the systems I had in place, I'm at a point in my life where I genuinely love the process of teaching and mentoring and inspiring students and helping them along their journey.
Yeah, I can't agree with you more. I have the same feeling toward teaching. And again, even though I've been doing it for 23 years, since it's a second career, it always still feels new. Tell me more about medical assisting. Like, what would be the responsibilities of a medical assistant?
Well, we do have a scope of practice that we have to stick to, but for the most part, we're helping patients with daily living activities. We are assisting the nurses, assisting the doctors. Medical assistant has to be skilled in performing EKGs properly, drawing blood and phlebotomy techniques, checking blood sugars, certainly checking vital signs manually and automatically. I get a lot of students who come in, and I'm very particular about manual blood pressures and doing them correctly. And I don't like to introduce them to the Dynamap, which automatically takes a blood pressure, until a few months into the program. Because as soon as they see that machine, they feel as though, why am I doing this manually when I can just do it with a machine? Then that opens up the discussion about how much more accurate a manual blood pressure is and how important it is. A doctor's not going to prescribe a cardiac medication from the results you got on a Dynamap versus a manual blood pressure. So I'll teach precise vital signs taking, respirations, pulse, blood pressure, pulse ox, temperature, of course. So in a hospital, you're doing a lot of daily living. In a doctor's office, it's a little different, but you are the first person that they meet when that patient walks in. You'll usually take the patient back to the exam room. You'll talk to the patient. You'll build a relationship with the patient. The medical assistant may be the first person this patient is telling their problem to, their ailment. They haven't told their family, they haven't told their loved ones, they haven't told their friends. They're telling you as the medical assistant. So communication is also huge. You got to have active listening techniques and know when to ask open-ended questions, when to ask closed-ended questions. It can be pretty complex, but it's about building a relationship with the patient and following the doctor's orders.
Okay, so what are some of the techniques that you employ to teach your students?
Well, I'm a little old school when it comes to using a PowerPoint, but I'll enhance my PowerPoints with things like memes to make the material more relatable and engaging to the students. I'll add interactive games to reinforce learning, keep the energy high in the classroom. I encourage the students to ask questions freely, creating open and supportive environment. I want my students engaged, speaking up. I don't want them to be afraid to give me the wrong answer. It's really a lot of times it's a confidence issue. So I encourage them to give me an answer, even if it's wrong. I incorporate coloring activities when it comes to anatomy and physiology, things like the heart and the lungs. I think this helps the students visualize and memorize the complex topics of the anatomy and blood flow, for example. I'm all about creating hands-on mind-body connection in the classroom by using the colors, sounds, visualization. Basically, I try to activate different parts of the brain and make learning more impactful and memorable for the student. And then, of course, we have hands-on in the lab that provides a real-world practice with essential procedures like EKGs and injections and vital signs and blood draws. Role playing and scripting exercises to simulate patient interactions, sometimes even maybe a frustrated patient or a scared patient. The students will work out these role plays and this scripting in the lab. And that definitely builds confidence because then when they're out there in the real world, they've already come across this. They already
Yeah.
know how to handle the patient who feels they've been waiting too long in the waiting room, or the girl who comes in who's real frightened about some symptoms that she might have for the first time. And while we're on the subject, we're real excited here. Next year, we're going to be introducing virtual reality into our curriculum. The students will be literally immersed in a virtual doctor's office caring for virtual patients.
Wow, that's neat.
Yeah, because I can teach a student about diabetes, signs and symptoms, and how to administer insulin on an injection pad. But to be in a virtual doctor's office with a patient experiencing a diabetic episode and you're the MA, it's definitely something the student will remember. The cutting edge tools promise definitely to be a big hit with these students, and I really think it's going to help them in the real world. And there's a platform that we use that has all different kinds of medical scenarios and different environments too. Although we mainly use the doctor's office, but the students are excited when they see me start to take out those headsets for sure.
That's pretty cool because I know that there's some pretty good anatomy stuff for the Oculus. I got to check it out a little bit more. So I'm assuming that to be an MA, you need a certificate or a degree of some kind. What would that be? And how long is the program? What kind of classes do they need to take to get out in the field working?
All right. Well, our program, the medical assistant program, for example, is typically about 6 months. In the field, some doctors may prefer some kind of degree, but it's not necessary. The certificate is usually the fastest and the most common way to go. There is the Associates in Health Science that Camden County College offers. In fact, our program, which is a certificate program, rewards students with 23 credits towards a associate's in health science with Camden County College. So that's a nice benefit, but it's not necessary. But a lot of students will use this course, this medical assistant course, as a stepping stone to something else, nursing or some kind of specialty medicine. We've had many success stories of students who started out with us here and have gone on to become physician's assistants and moved deeper and higher into the field, which is really nice. But to answer your question, they learn anatomy and physiology. They learn medical terminology, some administrative, so some front office stuff, and of course the clinical skills. So we teach them all that, and then they're prepared to sit down for the RMA, which is the Registered Medical Assistant certification, or the CCMA, which is the Certified Clinical Medical Assistant. And then from there, the world's their oyster.
What's the difference between the RMA and the CCMA?
The RMA is more, you learn everything. You learn the front office stuff and you learn the clinical. So you're learning insurance company jargon, how to make appointments, how to answer the phones, literally the front office. And then you're also learning how to greet a patient, how to room a patient, how to take their vital signs and such. This CCMA, Certified Clinical Medical Assistant, is just that. It's take the front office stuff out of it, and you're skilled in clinical, taking vital signs, doing EKGs, drawing blood, and things of that nature.
Okay, got it. So this is kind of exciting for someone who's interested in being in the medical field in general because you can get into a program and within 6 months or so, you can have a job. And then if that's your goal, then great, you're good to go. But you can also probably take a few extra classes if you're one of these people you mentioned who go on to become a nurse or a physician assistant. But you're marketable, you can start working.
You can start working. It's a great start to a career path or just to a new career. Like I said, I was a medical assistant for many years and I loved it. It's a very rewarding career. And from there, keep your eyes open and see what you like. Maybe from there you move on to nursing. Maybe you move into physical therapy or pharmacology. There's so many different aspects of the medical field, and it can all start with medical assisting because you're going to see everything.
So let me ask you this. This will be my selfish question for my own interests. What would you say is the most important anatomy and physiology topic for medical assistants to master?
That's a good question, Steve. I would have to say I would have to go to the heart of it, if you will, the cardiovascular. And the reason for that, the cardiovascular system is it's a cornerstone topic for medical assistants. It's essential for understanding so many patient conditions, and it also helps when interpreting the vital signs, where the pulse is coming from, where the blood pressure is coming from. So definitely cardiovascular, but not just blood flow and layers and valves, also the conduction system of the heart, because that leads us seamlessly, at least I try, seamlessly into EKGs. So once they understand the conduction system of the heart, and then I take them and show them EKGs and electrode placement and how to read these EKGs and the PQRST waves, again, it helps me explain it to them in a way that's interesting, I hope, to them. So I would have to say it's cardio, but outside of A&P, if you don't mind, patient communications. That's definitely huge. Knowing the science is definitely essential, but being able to effectively communicate with patients and the family members about health conditions and procedures that are involved, it's definitely vital for building trust and providing excellent care is that communication skill.
I tell my students that the exam starts the second the patient walks in the door because you're observing every single thing that person does. If they're slurring their words, if they're shuffling their gait, all of those things matter. There might be symptoms they don't even know yet, but you observe them. Also, you want to make sure that they're comfortable with you, right? So that way they're willing to tell you things that you need to know.
Right. There's so many more assessments besides just a physical assessment. All these things matter. Like you said, when you come out to the waiting room and call the patient in, that's when it starts.
And just to backtrack to cardiovascular, in case anyone's curious as to how important that is, it's episodes 39 through 48 of the podcast are all covering the circulatory system. So I tell my students that's a top 10 and they know exactly what I mean. Top 10 cause of death in the United States, right? So if we get into the endocrine system and we talk about insulin, I'm like, this is a top 10, everybody. And cardiovascular is number one in the world, heart disease. So yeah, it can't get more important than that. That's a good answer right there. So, Dave, this has been great. I've learned a ton, and I would like to know how my listeners can learn more about you and your program. Any socials you can direct them to?
I do. On Instagram, it's RMA underscore clinical underscore lab. I encourage my students and your listeners to take a look at it, especially if you're maybe already in a program. I put a lot of practice questions and things like that on there. Or if you're just thinking about possibly entering the medical field, I think it's a good place to start. I want to say that I was listening to your podcast. I've been listening to you for a while now, and those cardiac episodes you mentioned are favorites of mine. And I also encourage my students to listen to your podcast.
Oh, thanks. I appreciate that.
Yeah, and I really enjoyed that Mythbusters.
Oh, yeah. I did that one a while ago.
Yeah, because I'm surprised how many of my students come in and when I start the hematology topic, I'll ask them what color is blood, and I'm surprised that usually 50% of the class will tell me that blood is blue.
I was inspired for that one because when my kids were about your daughter's age, they were coming home with worksheets from school where there was myths that are being perpetuated by their teachers saying like blood is blue on the inside of your body. And I had to email the teacher and like, stop telling people this. It's not true. Well, Dave, thank you so much. I really appreciate you coming on. This has been really, really informative. I think that the listeners are going to get a lot out of this because this is a field that I think is very, very ripe for the people listening to this podcast.
Great. I'd love to meet them. I'd love to talk about the program and talk about the field. It inspires me, and I hope to inspire others.
Well, I think you're already doing that. Thanks a lot, Dave. I appreciate it.
Okay, Steve. Thank you. Bye-bye.
Once again, thank you so much to David DeVenti, Instructor of Medical Assisting and Supervisor of Allied Health and Workforce Development at Camden County College in Southern New Jersey. I learned a ton that I did not know about this exciting career. Just so you know, in the show notes, I am posting links to David's Instagram account, his college's website, and the book he mentioned, Atomic Habits by James Clear. I will also tag them all on my Instagram account, Student Help 4AP. That's the number 4, AP.
Bombas makes the most comfortable socks, underwear, and T-shirts.
Warning, Bombas are so absurdly comfortable you may throw out all your other clothes.
Sorry, do we legally have to say that?
No, this is just how I talk, and I really love my Bombas.
They do feel that good. And they do good, too. One item purchased equals one item donated.
To feel good and do good, go to Bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
Okay, without further ado, let's start the respiratory system. As you probably are aware, the respiratory system is about moving air in and out of your lungs and exchanging oxygen for carbon dioxide. That is the gist of what we're dealing with our respiratory system. But it does more than that. It's not just about that, but that is the primary goal. Why do we need oxygen? Well, we need oxygen to make most of the ATP that we use in our bodies. ATP, again, is our energy currency, and we need it for our cells to function. And if we have oxygen present, we can take a molecule of glucose and using aerobic respiration get up to 38 molecules of ATP from that one molecule of glucose, depending on which tissues we're talking about. But there's other functions of the respiratory system, like acid-base balance, voice production, right? So you're going to push air through your larynx, which is going to vibrate your vocal cords, and that is going to create your voice. And so it is important for language and communication. Acid-base balance as well, because we're going to see that carbon dioxide is mostly transported in our bodies as carbonic acid. So it's going to lower the pH. So we're going to use our respiratory system to adjust the amount of acid that is in our body's fluids. Also, you've probably noticed throughout studying A&P that organs of the respiratory system assist other organs as well. The nervous system, for example. The nervous system uses your nose for smell. So that is assisting another system. And also the lungs secrete an enzyme that is part of blood pressure regulation. So you'll see that a little bit later on when we get to the kidneys, actually, because it's all part of something called the renin-angiotensin-aldosterone pathway. And it requires an enzyme released by the lungs called angiotensin converting enzyme. And so we're going to see the lungs participate in other body systems, not just respiration. But we're going to focus mostly on respiration in this episode. As you're aware, humans have two lungs. There's a left and a right. Each lung is located in its own separate section of the thoracic cavity, deep to the skin, the chest muscles, the ribs, intercostal muscles, and the sternum. These bilateral sections are divided by a medial region called the mediastinum, which we know by now that's where our heart is. The lungs are the principal organs of respiration, and along with the larynx, which is your voice box, the trachea, your windpipe, and the bronchial tree, which is all the other vessels inside your lungs, they're all considered part of the lower respiratory system. Each lung looks kind of like a triangle with an apex at the superior aspect and a base at the inferior aspect, kind of just above your diaphragm. Following the pattern of the heart, the abdominal organs, the eyes, and other parts of our bodies, the lungs are covered by a two-layer membrane. For the lungs, this membrane is called the pleura. Each lung has its own. The deep layer is directly adhered to the lung surface and is called the visceral pleura. The superficial layer is directly adhered to the internal surface of the thoracic cavity, and it's called the parietal pleura. Between the two is a fluid-filled cavity called the pleural cavity, and it's filled with pleural fluid. That fluid lubricates the membranes so they don't stick to each other when we breathe. Because when we breathe, our lungs are going to expand and contract. So they're going to expand and they're going to hit the inside of your thoracic cavity, then they're going to contract. And we don't want it all to stick together. Each lung is divided into separate sections that are independent of each other. These sections are called lobes. The left lung is a little bit smaller than the right lung because most of the heart is on the left side, kind of getting in its way, which means it only has 2 lobes, whereas the right lung, which is a little larger, has 3 lobes. There's a deep depression in the left lung's medial surface, which is where the heart is going to be, and that's called the cardiac impression. The lobes are named for their location in the lung itself. The left lung, again, only has 2. It has a superior lobe and an inferior lobe. Whereas the right lung has 3. A superior lobe, a middle lobe, and an inferior lobe. In each of these lungs, the lobes are divided by fissures. In the left lung, we only have 1 fissure because there's only 2 lobes, and the fissure between those 2 lobes is called the oblique fissure of the left lung. On the right side, we have 2 fissures because we have 3 lobes. The fissure between the superior and middle lobe is called the horizontal fissure, and the fissure dividing the middle lobe from the inferior lobe is the oblique fissure of the right lung. If you look at the medial surface of the lungs, each of them, they have this area called the hilum. This is where the blood vessels, the lymphatics, the nerves, and what we call the main bronchus, which is the big main airway into each lung, can be found. All right, so now you know that the main goal of the respiratory system is to move air in and out of the lungs so we can get oxygen to our blood so we can make ATP. But it's also about removing the carbon dioxide from our bodies that results from making ATP. We use a lot of oxygen to make a lot of ATP to do all of the work that our cells need to do during the course of a regular day. Most of that work is stuff you don't even think about, like maintaining your body temperature or pumping ions into and out of your cells. But I want to talk about the path that air takes in and out of our bodies, which is called the respiratory tract. It's divided up into 2 zones: the conducting zone, in which air strictly moves back and forth with no gas exchange, and the respiratory zone, where gas exchange takes place. Let's start with the conducting zone. It begins with the upper respiratory system consisting of the nose, the mouth, and the pharynx. From there, air reaches the lungs via a series of branching tubes made rigid by hyaline cartilage. This lower respiratory system begins at the larynx and extends deep into the lungs. Air passes through a hole in the larynx and into the trachea, which is commonly known as your windpipe. That hole is called the glottis. When the trachea reaches about 1/3 of the way down the sternum at a location called the carina, it bifurcates into bilateral, separate cartilaginous tubes called the left main bronchus and the right main bronchus. So each lung is getting a main bronchus. Sometimes you'll see people call it a primary bronchus. At this point, we begin what is called the bronchial tree, which extends all the way to the microscopic pockets in your lungs called alveoli, which is the plural of alveolus. Each main bronchus divides into multiple lobar bronchi, or secondary bronchi, one for each lobe of each lung. So that means that the superior lobe of the left lung gets a lobar bronchus, the middle lobe of the right lung gets a lobar bronchus, etc. Those lobar bronchi then branch out into segmental bronchi, also known as tertiary bronchi. Each segmental bronchus supplies air to a section of the lung that is independent of the rest of the lung tissue. These regions are called bronchopulmonary segments. Each segmental bronchus branches into multiple smaller bronchi. These smaller bronchi continue to branch out and eventually lead to a tube with no hyaline cartilage called a bronchiole. Each bronchiole measures less than 1 millimeter in diameter. Each segment of tissue supplied by the same bronchiole is called a pulmonary lobule. Now, each of these bronchioles has 50 to 80 branches that are about 1/2 millimeter in diameter, and those are called terminal bronchioles. The conducting portion of the respiratory tract ends with these terminal bronchioles, and so does the bronchial tree, as each terminal bronchiole branches out into at least 2 respiratory bronchioles. Respiratory bronchioles mark the beginning of the respiratory zone of the respiratory tract, which means gas exchange can now start taking place. The respiratory tract continues on with the alveolar ducts and ends in the alveoli. And we'll talk more about alveoli when we talk about gas exchange, because that's where most of it is taking place. And that is basically oxygen and carbon dioxide diffusing across a membrane so that oxygen can go from the alveolus to our blood, and carbon dioxide can go from the blood capillaries into the alveolus so that we can exhale it. So gas exchange is one thing. Yes, that's what we need. That's what we need to achieve. But first, we need to get the air into our lungs, and we also need to get that air out of our lungs. And for that, we need to talk about pulmonary ventilation, also known as breathing. Pulmonary ventilation is divided up into 2 phases. Inspiration, which is inhaling, bringing air into your lungs, and expiration, which is exhaling, forcing air out of your lungs. They're very different. Inspiration is an active process, which means it requires muscle contraction. Specifically, it requires the contraction of key skeletal muscles called the diaphragm and the external intercostal muscles between your ribs. The diaphragm is a domed muscle that attaches to your inside of your ribs and also the xiphoid process of your sternum, and at a central tendon right in the middle of the muscle. The muscle's kind of like an open umbrella. It has a dome to it. When that muscle contracts, that muscle flattens out. So the bottom of the thoracic cavity drops because the diaphragm is the dividing line between the thoracic cavity and the abdominal cavity. Now, this is a skeletal muscle. It's a voluntary muscle, but you don't have to remember to breathe because there is neural control from the brainstem stimulating the muscle to contract on a regular basis for your respiratory rate. You can stop it if you want. You can hold your breath or you can breathe faster voluntarily. So you can change the automatic contraction of the diaphragm, but you don't have to think about it for it to happen. So this is where we fuzz the line between voluntary muscle and involuntary muscle. This is a voluntary muscle, but it's automatic. So we contract the diaphragm to flatten it out. The intercostal muscles, the external intercostals between the ribs, elevate the ribs and increase the lateral dimensions of the thoracic cavity. So when we do this with these muscles, the increase in thoracic cavity volume decreases the intrapleural pressure, which is the pressure in the pleural cavity. That creates a negative pressure, forcing the lungs to expand and creates a drop in alveolar pressure below the pressure in the atmosphere outside your body. So your alveolar pressure becomes lower than atmospheric pressure. Now, we know that air will move down its pressure gradient from an area of high pressure to low pressure. So that means that if your nose and mouth are open, then air will move down its gradient from the atmosphere into your lungs and alveoli. Expiration is passive. So when you exhale, you don't have to contract any muscles. This depends on the elastic recoil of lung tissue. Lung tissue has a lot of elastic tissue in it. That elastic tissue forces a recoil of the lungs back to their original shape and size after they've been expanded. So when the diaphragm contracts and the domes back up, the pressure inside the lungs will start to increase. So the intrapleural pressure will increase because of the elasticity of the lungs are squeezing them back down to their original shape and size. It's kind of like blowing up a balloon and then letting it go. Blowing up the balloon is active. It takes a lot of effort. You have to actively do that. But then all you do is let go of the nozzle on the end of the balloon, and the elasticity of the balloon itself will force the air out because that elasticity increases the pressure inside the balloon compared to the pressure on the outside of the balloon. And air will naturally move down its pressure gradient. Now, you can also forcefully exhale if you want. You can use the internal intercostal muscles, which will depress the ribs. You can contract your abdominal muscles. That will increase your abdominal pressure, pushing your diaphragm upward even higher. So you can forcefully exhale if you want, but you don't have to. But when this thoracic volume changes, the decrease in thoracic cavity volume increases the intrapleural pressure and alveolar pressure, pushing the air out of your lungs because it now exceeds the pressure in the atmosphere. This is ventilation. There are some controls to ventilation. Specifically, we'll talk about neural regulation, which means the nervous system is controlling and regulating how often you breathe. The main centers are in the brainstem. The medulla oblongata, which contains the dorsal and ventral respiratory groups that generate rhythmic breathing patterns, your regular at-rest respiratory rate, and the pons, which modulates breathing rhythm through the apneustic and pneumotaxic areas, which means that when your lungs become really too inflated, the pneumotaxic areas will be active and they will force you to do shorter, shallower breaths. But when you're resting, like when you're asleep and you have these long, drawn-out deep breaths, that's when the apneustic area of your pons is active. We also have chemoreceptors in your body that are constantly monitoring your chemical levels so that you can adjust your breathing to accommodate those. We have central chemoreceptors, which are located in the medulla oblongata, and they respond to changes in carbon dioxide and the pH of your cerebrospinal fluid. So when carbon dioxide levels go up and pH levels come down, your cerebrospinal fluid gets too acidic, we want to start exhaling more and get that CO2 out. We also have peripheral chemoreceptors, specifically the carotid and aortic bodies in the carotid arteries and also in the aortic arch. They respond to levels of oxygen, carbon dioxide, and pH levels in arterial blood. So when oxygen's low, carbon dioxide gets high, and pH levels get low, we want to breathe more. We want to get that CO2 out. We want to get that oxygen in. Let's talk a little bit about a physiology lab that you might be doing when you are studying the respiratory system in your classes. One of the ways we diagnose lung disorders is by measuring lung volumes and lung capacities. Lung volumes are the measurements of air we can move into and out of our lungs. And we call this pulmonary ventilation, as you know. We measure these volumes with a technique called spirometry. So you might perform this lab in a traditional lab setting, or you might even use a simulation. Either way, you should really be able to understand what spirometry means and what it does. A spirometer uses a tube that is connected to a device that measures the movement of air in and out of that tube. With a mouthpiece attached to the tube, a patient can blow into the tube and a measurement is taken from that exhalation. We can measure 3 basic lung volumes with a spirometer. Tidal volume, which is the amount of air exhaled in one at-rest breath. inspiratory reserve volume, which is the amount of air that can be forcefully inhaled in excess of tidal volume, and the expiratory reserve volume, which is the amount of air that can be forcefully exhaled in excess of tidal volume. What's also clinically important is how quickly one can exhale. The one volume that we can't measure by spirometry is the one that does not get ventilated, and that's called residual volume. That is the amount of air that remains in your lungs even after a complete, total, forced exhalation. Once we know these measurements, we can calculate the lung capacities. They include inspiratory capacity, which is the amount of air the lungs can hold at once after a forced inhalation, vital capacity, which is the amount of air the lungs can forcefully exhale after a forced inhalation. This is essentially all the air a patient can move with one big exhale, and it's very clinically significant. It measures how strong a patient's respiration is, which is a clue into what may be happening with their lungs. Finally, there's the total lung capacity. This is all the air that the lungs can hold at once and includes residual volume, which vital capacity does not. Spirometers come in many shapes, sizes, and costs. Simple spirometers are small and inexpensive, and oftentimes they'll show you the measurements right on the instrument. Another option is a computerized spirometer. The mouthpiece is connected to a machine that measures the volumes and records them with a computer application. Those data can then be saved and analyzed in that computer application. No matter which method you're using, obviously the mouthpiece you use should always be new and disposable or autoclaved in between uses. This will limit the chance of transmitting infections from one subject to another. Keep in mind that when you do spirometry, you're going to be collecting important data and analyzing them to help diagnose a potential respiratory condition. The diameter of the bronchioles, the surface area of the alveoli, the elasticity of the lung tissue can all affect the measurements that you collect through spirometry. Those things can tell you about a lot of really important diseases like pneumonia, where there's an infection causing a lot of fluid in the lungs, or asthma, where there is a restriction in how much air you can move at one time, or chronic obstructive pulmonary disease like emphysema, where there is a breakdown in the walls of the alveoli, which also means there's a breakdown in the elasticity of the lung tissue. Because as the lung tissue breaks down, so does its elastic tissue, which means not only do you lose surface area in the alveoli, which we'll talk about in the next episode why that's important, but also it means that exhalation is no longer passive. If you lose the elasticity of the lungs, then every time you exhale, you have to forcefully exhale. So imagine if every time you exhaled, it was like you were blowing up a balloon, and how exhausting that would be. That's what emphysema does. Emphysema is one of the chronic obstructive pulmonary diseases, the other being chronic bronchitis. These are diseases that were basically created by cigarette smoking. There are some non-smoking causes to these diseases, but for the most part, cigarette smoking causes chronic obstructive pulmonary disease.
You buy a pair of socks, that's 2 socks. You buy a pair of Bombas socks, that's 4 socks. Because one purchased is one donated. Socks are the #1 most requested clothing item in homeless shelters. So when you buy a pair of super comfortable Bombas socks, you're also donating a pair. Bombas customers have powered over 150 million donations. So Bombas would like to thank you 150 million times. But we only have like 30 seconds. Go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
All right, that's enough for this episode. In the next episode, we're going to get into some of the physiology of the respiratory system. We're going to talk about specific gas exchange and all the things we need to know about air and pressure to understand how gas exchange works. But that's for a whole new episode. I want to thank David DeVenti once again for being my guest. Thank you so much, Dave. I really appreciate you coming on and sharing all that great knowledge with us. I also want to thank you, the listeners, for constantly being so supportive and for leaving reviews and comments on Spotify especially, and also on Apple Podcasts. I've been seeing a lot of them coming up. Thank you so much. I would love it if you all could rate and review the podcast for me. That would be a really big help to make sure that we get this out to as many people as possible. Thank you so much. And also, thanks to those of you who are still emailing me. Even though I didn't have any questions this week, I get a lot of emails of just thank you from people. And I can't tell you how much that means to me. It is really exciting when I just get an email out of the blue that is thanking me for doing the podcast. I got one earlier this week where someone said that the podcast is the reason they're passing anatomy and physiology, and that means a lot. I'm sure that your instructor, and I'm sure that you as the student, is doing the most. But if I can be even a little bit of help to help you get that B or better in A&P, well, that's what this is all about. And then I'm happy. So thank you again, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media. Don't forget to check out my Instagram account and my YouTube channel, both called Student Help for AP. I'm posting a lot of stuff on there right now that you can watch and that will hopefully really help you understand this A&P stuff. Very special thank you out to my family, Bucks County Community College, and McGraw-Hill Education, where you can find my tutor video-based textbook alternative Anatomy and Physiology digital suite, already being used by several colleges and universities throughout the United States.